So, good afternoon to all watching. I am very, very lucky this afternoon to be joined by the fantastic Dr. Deepak Ravindran, who is a consultant in pain management, as well as one of the heads of a long COVID clinic here in the UK, which is a very, very good combo, I think, for the kinds of questions that I know that our audience will want to have sort of explored with you today. But Dr. Deepak, why don't I just hand over to you and ask you to tell me a little bit about your journey into, first of all, the pain management side of things. You know, how did you move from being someone who was a generalist probably into a specialist? What was your interest? Why did you head there?
Well, thank you so much, Susie, for having me and for allowing me to talk to your audience in the Facebook group, as well as for those suffering from long COVID, really. It's become now one of my passions and my interests in terms of long COVID there. And the similarities that I had noted with many other conditions that I was treating and looking after patients is what attracted me to actually also put my hand up when the opportunity came for setting up a long COVID clinic in my area. My background for those of you and those of your listeners who are going to be hearing me for the first time is that I'm a consultant in anesthesia and pain medicine, working within the National Health Service in the United Kingdom. I work in a hospital called the Royal Berkshire NHS Foundation Trust, which is in a town called Reading, about 20 minutes west of Heathrow, for those of your non-UK listeners there. And my training, my medical undergraduate training was back in India, but then I came here about 18 years ago and I have trained in the UK and I did my pain fellowship in London before starting my role here. And from the beginning, I've always been sort of interested in some of that fundamental aspects of pain management. And so in the UK and in India, in order to become a specialist in pain management, you need to have your basic qualification needs to be in anesthesia. So which is why after doing my basic undergraduate medical education, I did a postgraduate in anesthesia and then a super specialty training in pain fellowship before starting there. So it is a fairly longish journey that I had to take there. But again, even within pain management, when I started out as a consultant, I realized that pain in itself is so complex in terms that, you know, we are often taught that, okay, for every pain, there must be a structural cause, which I now know is not necessarily the truth at all. And we were often trained in the art of giving medications, which again, with all the problems of pain medication these days, we know that that's not the only answer. And so that's what began my search for the last 5-6 years in reading through the literature, reading through the mainstream medical literature, but also then going through the alternative or what generally has been outside of mainstream medicine, sort of complementary therapies or what we called as complementary therapies. But then we realize actually that even these therapies have now been examined microscopically under mainstream medical paradigms. And actually, a lot of them do have the scientific basis for being given and should be prescribed. But actually, that's the knowledge that medical professionals and healthcare professionals and the general public have not been aware or are still not aware. And I think that was why I felt that, yes, this needs to come to the general public. And that's why I wrote a book about it. But doing all of this, I realized that actually in my pain clinic, I was looking after patients with fibromyalgia, with chronic fatigue. I was looking after patients who had post-viral issues and they were coming with pain of various descriptions there. And that's why when long COVID happened, when COVID happened, I was aware that as a viral infection, there's a chance that there's going to be a percentage of people going to struggle for a long time. And I've often been interested in the fact that in the pain clinic, I see people 3, 4, 5, 6 years into their pain journey. And I thought, well, if a COVID patient then has these struggles after that, there isn't a system to actually support the multiple symptoms they may have, because our traditional medical model is very super specialized. There's a lot of siloed specialties, but there
Yeah.
isn't someone to look after them. And
Mm.
that's where I got involved in working with Professor Greenall from Oxford. And we wrote a paper together saying that actually this should be the time wherein we have a multidisciplinary setup that is there for
Mm.
the long COVID patients, which is going to look at them holistically from the outset and support them in their recovery journey. And my premise was that if we can get to these patients much earlier than 5 years, maybe we can shift their trajectory and actually improve them much quicker, unlike pain patients, wherein sometimes when they come down 5 6 years, there are so many things that have happened in the complexity of pain and lifestyle and their general health and other medical conditions, that unpicking it becomes very difficult. And I think that's why with my long COVID service as well, we've been able to get that interest, and my background in pain medicine makes me, I feel, more uniquely qualified to support these patients. Susie, as a matter of interest, I think I'm still the only pain physician in the UK who is leading a long COVID service. I think there are a few other colleagues who are part of the service, but I'm one of the, probably the only one still who's set it up and leading on it.
I think you're absolutely right, which was what interested me, and also your qualification now as a lifestyle medicine practitioner. So, you know, you're really taking on board the concept that we are systems, not just a unique set of symptoms, which are, as you say, treated in this kind of Western medicine way in a very siloed manner. And our whole kind of healthcare model is based around that kind of separation out of the human system into different sections, which, you know, is a very Western approach. And I think it serves its purpose in some way. But there, you know, when we have something like the COVID virus and the experience that many people have of that and how it affects all of us all at the same time, it's a very difficult approach to then just take one bit at a time to try to work with. And I'm wondering if some of your interest in really thinking about us as systems stems from perhaps maybe more of the influence in your own upbringing, you know, because I know Ayurvedic medicine treats systemically. A lot of the approaches from the Eastern side of, you know, thinking around well-being come from the mind-body approach. I mean, just talk to me a little bit about what your own thoughts are on that.
It's a very interesting question that you say there, and I've had some time to reflect on that. I think I came in with a very biomedical approach into medicine. Back in India, when I trained, it was very biomedical. The expectation was that we would look at evidence and everything would be looked at with the lens of a randomized controlled trial and the highest quality of evidence there. And I think the more I've gone through my career path in India, and then I've come to the UK and trained here and then been a consultant, I've realized actually that mainstream medicine is really fantastic when we understand the mechanisms very, very accurately, right down to the reductionistic level, which is, you know, like maybe some cancers, maybe some surgical conditions, maybe a pregnant person requiring a surgery, a cesarean section. Those are things that we understand fairly well the mechanism for. But for a lot of other things, we don't understand as yet the mechanisms. We have some ideas and we have some hypotheses, and based on that hypothesis, we drill down. But when those hypotheses are not right, mainstream medicine has tended to struggle and has preferred to just stay within the same hypothesis, even though it's flawed. For example, the cholesterol or the serotonin hypothesis, we just stick within that familiar boundary because we don't know what's outside there. And I think that's where I realized actually, if I think back as to how my grandma looked after me, you know, I caught jaundice when I was young, and she used Ayurvedic medicine.
Right.
My uncle was actually a manufacturer of homeopathic. He's still a manufacturer of homeopathic medicines and is in India. And my family and my parents do believe in homeopathy as a alternative even though I go and tell them that the evidence doesn't really stack up, even among alternative therapies and complementary therapies, homeopathy is still failed to stack up there. But when you look at it from the perspective of placebo response, do we
Right,
really understand what the
right,
placebo is meant to do? And
right,
if a placebo is actually generating the same chemicals in the brain that a drug releases, because that's what we understand now as to how strong the placebo response is,
mm, mm,
then actually that expectation effect is huge. We do not understand how to harness the placebo response and the expectation effect. Maybe homeopathy has an element of that manner out there, which we still may never fathom with
right,
our expectation. I think all of those has made me be a bit more humble and
mm,
probably accept that the Eastern philosophy, the Chinese and the Asian and my sort of old forefathers' philosophy of looking at the person holistically is probably coming back into fashion. And I think the pandemic has made us realize that if you want to focus on well being, if you want to focus on health as a whole, then we need to probably take into account what are the factors around lifestyle, around social, around all of that that feeds into this well being. And we
mm,
now actually have the evidence to talk about the social factors, to talk about
very good,
lifestyle factors, to talk about relationships and how important they are in actually some of the biochemical signals that
right.
take place in our human nervous system, the immune system. So I think now I realize that I probably owe a lot subconsciously to those kind of Eastern philosophical values, but
Mm.
I am able to harness and probably articulate that better in a Western framework.
Yes, and I think that is one of the challenges, isn't it? Because for many, many years, people that worked in that alternative therapy world were very much dismissed. But now I think, there is more and more evidence allowing that sort of practice, those different practices and treatments to be really, really welcomed into the treatment protocol for many different types of conditions. And actually, long COVID has found people, going out there and trying all sorts of things because there were just simply no solutions to many people. And as you know, I'm sure we can move on to talk about this. So many people get tested for all sorts of things that, the average kind of Western medicine is looking for, and they get given the all clear. And yet they are still the most unwell they've ever been in their lives, for some
Yeah.
people, deeply traumatically so. And it's a really, really difficult place to find yourself. And so I'm just really, I would love to hear more about what is it in your clinic, because you're one of the kind of heads of this long COVID clinic, which is obviously helping people. You must come across patients like this every day. What is the protocol that you're offering them? And, how can we learn? There's a whole audience who'll be listening to this with kind of, their ears really cocked. What is it that we can learn from you about how people can help themselves? Because I think the more we can empower people to do things for themselves and not just sit on a waiting list to then be told in 4 months' time, I can't find anything, go away. The healthier we're going to help, those people become. So just talk to me about that typical scenario. We're not talking about those that have got diagnosed organ damage or specific issues that have been, found upon testing and now being medically treated. We're talking about those that are sort of left slightly out in the open.
Yeah, no, very good point there. And I think I will have to divide this question up into a couple of ways. One is to say that at the outset, um, for those of your listeners who are not within the UK and those even within the UK there, I work as part of the NHS. So the long COVID is part of the NHS, and the NHS is quite clear that we would want to provide treatments or assessments or even tests that have shown to have definite prognostic and treatment value. And that is a decision that the NICE guidelines, when they set up and they said this is how a long COVID clinic should be set up,
Yeah.
they suggested a battery of investigations and assessments and treatments that the task force at that time recommended.
Yeah.
And to a certain extent, clinics have been tied by that fact that they
Yeah.
can only offer those things because that's what will be paid for and supported and accepted. And when you go out of there, you're going to be challenged by your commissioners or the people who
Right.
ask you to provide. So that's a necessary, or almost sometimes, depending on which perspective, from the patient's perspective, can be unfortunate or fortunate in terms of how it ties the clinician and the patient in a relationship of that manner. The
Mm.
reason I say all this is every clinic I have patients who do come and tell me, I read about this and I would like for testing to this to happen. I heard about this or I saw this on social media and I think I want to get tested for it. And what I have in my clinic is I have access to specialists who are able to support me when some of these unusual tests come along, things that fall outside of what the NICE had said that I can do. And
Mm.
these slightly new things come along, I have to ask those consultants, whether it's as an endocrinologist or a diabetologist or a gynecologist or maybe a neurologist, and they would turn around and say, well, no, there's no evidence for that. So I don't think I can authorize that, Deepak. I don't think that's fair.
Mm.
And to a certain extent, I have had to have those conversations with the patient to actually say, I know you're worried about this, but right now that's not something that the NHS is able to provide. Now, that is a conversation that is fraught with challenges, as you can appreciate, because some of the patients are quite keen for this to be tested,
Right.
and they do believe that there's an opportunity that things can move forward.
Mm.
The flip side to this is that the positives are that we have got, in my clinic, I've got access to a physiotherapist, I've got access to a GP who is extremely knowledgeable in this kind of complex long-term conditions, even before COVID happened and long COVID happened.
Mm.
I've got myself with that experience of lifestyle medicine that I bring there. And then I've got an extremely sort of very well qualified fatigue and pain physiotherapist, a respiratory therapist there, an occupational therapist. So this is our core assessment clinic professionals. And then at the drop of an email with some half a day sessional support, I've got access to respiratory consultants and other colleagues from the rehabilitation or the neurology department or cardiology department. So they're all there to provide added support and advice and even see patients and organize required. So this is my clinic profile and setup. And when the first side of funding came to set up this clinic, we were told that the funding is mainly for assessment and a little bit of treatment. So we were focused on making sure that our patients were first of all assessed. So the people who are waiting have never been seen by anybody in primary care as well. They couldn't even see their GPs because of
Yeah.
lockdown, and they couldn't
Yeah.
see there. And we initially thought that the clinic would be mostly for people who had been admitted in hospital
Right.
or who had been in ICU. But you are probably aware, and maybe most of your listeners are, patients who are actually mild, according to everyone, mild to moderate
Right.
COVID, managed at home or in the community with
Yeah.
a pulse oximeter, but they are the ones suffering the most. Even
Yeah.
now,
Yeah.
87% of the referrals that come to the Berkshire Long COVID Clinic have
Mm.
been from primary care, by which I mean these people have not been seen even
Yeah.
in an emergency department or in a hospital setting or ICU. So that is the huge number
Mm.
of cases that are in the community. So for them, the first thing that the clinic has to do is examine them, assess them, investigate if required, any more investigations. GPs already do a standard battery of tests and then refer to us.
Yeah.
We then add something more if required. But most of the patients, we initially were doing some scans of their chest if required, because breathlessness was a very common symptom.
Yeah.
But pain, unless and until there was a history of trauma or injury, we were able to talk to them about the need for a scan of their neck or their back. But yes, we could do all of that stuff if required. So that is where we were doing that extra scans if required for the chest, for the brain, for their lungs, for their back, and then neck. So that's what we were doing. We were doing some extra breathing functions like spirometry that was required, and then a better battery of blood tests to look at whether there has been a strain on the heart or an echo of the heart or ECGs and all of these stuff there. So that's what we were doing and we are still doing in the long COVID clinic. And in the last 4 months, when we now have funding for treatment, so now the NHS has released more money for actually providing treatment. After the second lockdown, we have now rolled out treatment. We've got some more community-based physios who are going to be appointed now, community-based psychologists and therapists to support. And that's what we are now rolling out in our clinic as, okay, we've now assessed all these people. So now can we start the process of making sure we treat them, we support them, we signpost them to any resources or other treatments that are available, and then get some more support for other treatments as well if needed.
Yes, I think I mean, it sounds like, obviously within the NHS progress is slow and, hopefully steady, because, as I listen to you here about how the clinic is beginning to kind of grow in response to what's actually needed, that sense of community and helping educate people and giving them more sort of physio-based support and respiratory rehab support. I think, that's one of the many things that we're all kind of aware that is what's needed. We need to feel supported. The moment where someone is given a negative test result, you would want it to be, oh, well, great, well, I'll just stop being ill then. But it's not for most people. For most people, if something doesn't show up, if their D-dimer results are fine, if their, hormone tests are fine, if their scans are fine, but they're still feeling really ill, it's such a confusing place to be, and people can feel really isolated. And so to hear you talk about that need for kind of community connection and support and helping people to kind of learn about how to help themselves, that is really fundamental, I think, from my perspective, and from, having listened to so many stories for the past 18 months, including my own. That's the way forwards. One of the things that I've set up is a kind of program, a physical program, a rehab program, which involves breath work and mindfulness meditation and physical retraining. But we also have this live support group, which I have to say is one of the most extraordinarily powerful things that I think people could attend, because, you've got 50, 60 people like a hive mind sharing their stories, sharing their experience, suggesting things to try, sharing reassurance. Today we just had the group and people are worried about getting their booster jabs. They may have had a terrible response to having their first vaccine. It may have set them back in their recovery. They may be terrified. And, you get 2 or 3 people just saying, do you know what, actually, it was really great. It really was fine for me. And suddenly You've got someone transformed in that moment to not being in fear anymore and allowing themselves to go and get perhaps the protection that they wouldn't have chosen afterwards. And actually, it is that kind of thing that I'm hoping the NHS moves more towards in their model, about helping this particular group of people and others like them to actually support each other. I think we're so focused on seeing one person at a time, and we sort of forget the power of group support and group healing and that kind of wisdom that we can share with each other. Because from my own perspective, education has been one of the most significantly useful things to my understanding of what was happening to me in my own body. So I didn't really know the term dysautonomia before I got COVID.
Yeah.
I certainly didn't know about mast cell activation syndrome, so it's been a real eye-opening and sort of brain enlarging experience. And I don't think I've ever talked about my autonomic nervous system quite as much as I have.
Yeah.
But we're all learning about what these things do and what it means and how we can help ourselves. And people are desperate for the information. So, interviews like this are really, really fundamental to helping some people who may be just sitting and waiting for their one-on-one appointment with someone who's hopefully having a good day and has got time to really listen. And, this is probably better than any appointment they could probably have anywhere, because, hopefully we can impart some reassurance, if nothing else, that there are things that you can do. So
I think that's where we are going forwards there. I mean, that's what we want to do with any of these long COVID clinics. And I believe there are a few of the clinics around my area here, whether it's in Oxford or whether it's in south of England, they are focusing on providing these kind of group-based approaches.
Right. Yeah.
the reality, I think, is groups like yours are going to be always more powerful because they provide the ongoing support,
Yeah.
which sometimes NHS services have struggled to provide. Because you can provide a group program, even within the pain service, I knew even before the pandemic, we'd offer group-based pain management programs. The patients would really love it, and they see and interact with other people who are like them, struggling with pain or with long COVID. They get that there. But then once the group is over and they've been discharged from the clinic, then
Right.
it's left to them to sustain it. And that requires some kind of added support for which the NHS traditionally has not had the funding or the
Right.
way to do it. And I hope that long COVID, as you said, gives the spur to do it. Remind me to tell your listeners as well, because that's what we've done is at least we've got this funding from NHS charities to provide some mind body therapies
Yeah.
outside of what the clinic is meant to do and offer there. And I'll talk to it about it a little bit later, but sorry, I interrupted you. Go on.
No, well, I was going to ask you to move on to your protocol, your mindset protocol. And so Deepak has written a brilliant book called The Pain-Free Mindset. Obviously, we're going to give you a little plug there because you're giving us your time for free. And you also describe yourself on your website. If anyone wants to have a look at his website, it's there. You can read a bit about him as an upstreamist. And this is a term that I know when I interviewed Dr. Boon Lim, the cardiologist Boon Lim, he also talks about looking upstream, stop just looking downstream for where the kind of pools of debris have landed, look upstream and see what's going on. So I want you to just talk us through your protocol, your mindset protocol, because I think it's a really lovely structure that some people who are perhaps newer to their long COVID or their post-viral recovery, whatever it is that they're recovering from, actually could really start to kind of just take on board. Because I think it's really simple and it gives a framework, because sometimes people are all over the place, like, what should I be doing? What should I be thinking about? So talk us through, because I think it's perfect.
So for your readers, so while I wrote the pain-free mindset with an eye on knowing the complexity of chronic pain, where there might be so many contributory factors, and the mindset was an acronym or is an acronym to look at pain, I also realized actually that there is a potential and there is, a very big opportunity for having a template, a model like that for any possible long-term condition, or for that matter, for any healthcare condition itself. Because fundamentally, it comes down to understanding that the human system or the human being, you are one person, and you have a system that is looking out for you at all times, wanting to protect you. That is the bare essential minimum, whether you look at it from an evolutionary perspective or that you are an organism that needs to survive, to thrive, and to then procreate, and at some point die. That is unfortunate. That's a cycle of life. And it means that there is then a nervous system and an immune system that is constantly looking out to protect us and to look after us and to sustain us and to ensure that they are deeply communicating with each other to assure us of our continued existence. So that is the first premise, that we have a nervous and immune system that's present and linked together. And we've always approached any healthcare condition as a very reductionist model, as if we give a drug or if we give a surgery and then we do that, then it'll all be okay. But then, therefore, you're assuming that the nervous and immune system is not connected to there and are just dependent on one structure to do the job. That we know from even mainstream science that is not the right thing anymore. So my suggestion and the template of the mindset is, for any condition, including long COVID,
Agreed.
there is a medication. The M stands for the medication. So there may be medications you could consider if you've got a rapid heart rate, or if you've got some breathlessness. You might consider inhalers. You might have a mast cell intolerance, so you might consider antihistamine. So absolutely fine. There may be a role for the medicines in calming the symptoms. There may be intervention. So for example, one of the things that you asked me in the introductory email is around microclotting or FRSs and these things that are being talked about. There have been other interventions that have been talked about. There's virtual reality as an intervention that can be talked about for long COVID. So there may be interventions like that, or injections that you come across, or infusions that you might have heard about. And again, that will help in calming the system down, and you may consider that. But my plea to all people with long COVID in my clinic, as well as pain management before long COVID happened, was to say, don't stop with the M and the I, because if you are wanting to regulate your immune and your nervous system and make it feel safe, then you need to think about what are the other things that it is going to consider as danger or a threat that it needs to protect you from. And all of those factors will also have to be paid some attention to, and some kind of change needs to be looked at that, because if you can bring all of those into alignment, then the M and the I is also going to work even better. And that's where the N is for the understanding of the neuroscience and the stress. So what does a hyperactive immune system do to your nervous system? How can it signal certain chemicals called cytokines, which can actually drive the nerve circuits into a higher level of protection mode, or vice versa? How can a highly sensitized nervous system cause the immune system to put out even more immune chemicals that forget which is yours and which is somebody else's foreign, and becomes like an autoimmune, attacks its own. So this is something to be thought about. The D in the mindset looks at the diet and nutrition, because the biggest place where the immune system is present is in the gut and all along the lining of the intestine. So maybe what you eat, the kind of food that you eat, when you eat, what you eat, how much you eat, can also impact on the immune system and confuse it. So if you optimize that, you can make some change to immune system. The S is for sleep, and the importance of sleep, and how a particular number of hours of sleep gives your nervous and immune system to do a bit of MOT, to do a bit of self-cleaning job. So how can you optimize sleep? E is for exercise or physical activity. Exercise not in the sense of doing something regimented, but physical activity and movement of any kind, because we now know that any kind of movement builds certain nerve cells, creates a release of certain chemicals that allow for blood flow to muscles and change that. So that is very important as just as a lifestyle pillar. But even within long COVID, we realized that it has to be a properly monitored movement, but actually some movement is likely to be good even in the most fatigued long COVID individual, because it improves a bit of blood flow and prevents a bit of deconditioning. And I think while pacing is being understood even better now in the context of long COVID, movement has never been in question. I think graded exercise has received a bad rep, rightly so, because it's not right. But there is some value in how you achieve the movement. If you can achieve movement that is considered safe by the nervous system, whether that's a gentle yoga practice, or whether that is a gentle Tai Chi technique, or even some stretches, then that still is good enough movement, I would say. And the last part is T, which is the therapies of mind and body. And that is something we've traditionally dismissed, but I wanted to bring that into the template and the model to say that while we may now be in a healthcare system which does not want to recognize or doesn't have the mechanisms to recognize and support and fund it, we as human beings cannot forget the importance of what relationships, mood management, emotional connection does to a nervous system and an immune system. That is a very powerful and a non-drug way to bring the immune and nervous system back to some equilibrium. And if that can be achieved with breathing exercises, with a walk in nature, with interaction with your fellow human beings or people that you love, then I think we should try to promote that in whichever way possible. And I think as doctors, as physicians, I feel that if we can actually vocalize it and articulate it to our patients, then they will feel that, okay, if this doctor has actually said it matters, then maybe it's worth doing it, because otherwise it just becomes something that they have either heard on social media or somebody has told it, but their implicit assumption is their GP or their consultant hasn't told them, then maybe that's not as important as it ought to be. And I want to change that conversation.
Oh gosh, me too. The amount of times I've seen people say, yeah, that's all well and good. You're kind of go and see a counselor, go and do a bit of gentle movement, go and do your breathing. But when are the drugs going to arrive that will fix us? It's like, well, actually, I don't know if they ever will, because there's some work that only you can do to bring yourself back down into a self-regulated state.
Yeah.
And that's a really, really difficult mindset shift for a lot of people to make. Because I absolutely know there will be some people just sitting and waiting. What's going to be my silver bullet? Where's the drug that I can either buy or be given that will give me my health back? And I think it's a really challenging mindset shift for a lot of people to take on, because it involves doing some work yourself. It involves stepping back into your own, sort of driving seat in many ways. And when you're feeling ill and you're exhausted and, you have all of this kind of stuff happening because you might have lost your job, your relationships are being challenged, you might not be the parent you want to be, all of those things. And you're thinking, gosh, now you're telling me I need to do some movement every day and do this breathing rehab 3 times a day. And I might, it can feel overwhelming. So I can understand.
I mean, I completely get that point, because that is a very challenging and difficult place for the patient itself. So what I do tell them is, okay, I will give this medicine, but can you think? So it is a little bit of a, I wouldn't say leverage there, but actually say, okay, let's think about this medicine, because ultimately the reality is that our understanding of a complex condition like long COVID, especially something that we're only now understanding about how complex it is indeed,
Right.
the number of theories that have come through, even in the last year, you as a long COVID patient and other people in your group will be aware, we've circled through mast cell activation to microclotting to other ACE receptors, to take it from the biomedical, biomechanical receptors and various nerves to actually viruses still being present. There might be some viral debris, or there might be some changes in your nervous system, in your immune system. All of these theories keep floating about to say, or, all of these, and we still don't have an answer forward to say that this is the mechanism that's there in 80% of people, 20% will have this. And I think my review of the literature and from reading all that and also seeing the patients in the clinic, we've had about 1,000 referrals up to now. We've seen about 600, 650 patients in the clinic up to now. And I can tell you that in a given day where we are seeing about 15 to 20 patients, maybe 2 or 3 patients at the most will have a similar set of symptoms.
Yes.
Otherwise, everybody's experience is quite different. Yes, they all have fatigue. They all have pain. They all have, to a certain extent, of brain fog or a bit of shortness of breath. But the sequence in which it happens, the way it troubles them, the way it impacts on them and how severe these conditions are and the ups and downs that they have in a given day, there is no pattern. And actually, if you want to do a trial or a study, one of the first exclusion criteria is you need to have similarity, because then you need to take out all the variables so that you can give a drug and actually say, is this drug effective against nothing? And therefore, is this drug superior? When you have a condition that's so challenging, how are you ever going to get a group of people that are broadly similar enough to give a drug that is consistently superior to placebo? I find that while patients and your listeners may not want to believe me or find that challenging, I think that's a very big challenge for modern medicine, because the way the trials and studies are constructed, we will struggle to find something that will be the silver bullet. There will be some treatments. There's, for your listeners, this is such an encouragement point. There's $1.2 billion of research that the US is doing on biomarkers and biochemical markers for long COVID. We have about 30 million pounds in the UK that's been given for looking at research into long COVID. So there is definitely going to be something
Yeah.
some chemical markers that will come for
Yeah.
long COVID. And as a result of that, there will be a few drugs. But I can give it to you in writing right now that we will not find one drug that works for all long COVID patients. So you will still need, other than the M, you will need to embrace the other elements of the mindset. And I completely agree. Some of them may find it too challenging to do it all in one go. They may have to start with one after the other. But I think eventually they will find, and everyone that I've met, the people, I have had a few patients in my long COVID clinic who have recovered or who are much better. And when I asked them, well, actually, what did you do? Some of them would have started it after they've met me. So they've done those elements of the mindset. So they've put in consciously, they've realized that, okay, they need to make an effort to bring some of them in.
Yeah.
But there are others who actually have said, okay, this is how I did it. And even before they've seen me and they've improved and they come to the clinic, they will say that they have done some acupuncture or they have
Right.
started going out for a walk.
Yeah.
They have reduced the stress at their workplace and they have gone part-time, so they have a bit more time to themselves. They have invested in self-care. They have improved their sleep. They have started to eat healthy. They are taking maybe some versions of low histamine diet. They're taking more prebiotics. So
Yeah.
I have not had anybody who just said, I suddenly became better and you know what, I just took one drug.
No.
Everybody whose success story has improved, they have been able to do it because they have put in a combination of techniques.
Yeah. Agreed. And I think that sort of marks my story very well in the same way. I tried acupuncture. I did find that it helped me. I did move, constantly, even when I was at my worst. Within 4 days of coming back out of A&E, I was back on my yoga mat, just breathing and trying to calm myself down, because my sleep was all over the place. My adrenaline levels were so high, I couldn't sleep more than 45 minutes. And I knew that was really, really important. My doctor gave me antihistamines to help with the sleep, and bang, suddenly I went, oh, something else happened. I'm sleeping better, but there's some other stuff that's changed as well. So, it was a kind of shot in the dark that
Yep.
he'd given me, because the sleeping tablets he tried me on hadn't worked, but antihistamines did. And but the game changer was what else they happened to change, so it was a kind of, everyone is kind of experimenting with all sorts of things.
Yep.
And I think it is, it is a really interesting shift for a lot of people. And I've had this conversation with a lot of people. The kind of after effects of the COVID infection, the long COVID experience, it makes us look at our lifestyle. It makes us look at who we are. It makes us look at how our lives were. It makes us look at the concept of self-care. And, for many people, the idea of self-care was a glass of wine or a bottle of wine on Thursday night, and maybe 2 bottles of wine at the weekend, and maybe a lie-in if the kids can stay in bed in front of the TV long enough. And that's self-care. And actually we push ourselves. Society expects us to push ourselves. We're expected to do more, be more, show up more places, work harder, work longer, always be reachable, always be on your phone, always be contactable, push, push, push. And, I think a lot of people have gone, oh my goodness, I don't want to go back to that. I can't go back to that, so I want to get myself better so that I have a completely different kind of life that's much more respectful and in tune with my own body and mental health and well-being needs. So I think, that this is where your lifestyle medicine really comes into play. And I think it's fundamental for people's understanding of, well, how do you keep yourself healthy? Because this kind of viral, pandemic, I'm sure this isn't the last time we're going to see anything like this.
No, unfortunately not. It's just the
Again, it will come
frequency,
again.
that's all.
Right. And, we might be unlucky enough to see something else similar in our own lifetime. Our children certainly will. But actually, these fundamental stepping stones around how do I keep myself well? How do I keep myself healthy? These are really important lessons that a lot of people are learning right now, whilst trying to get themselves better from this one. And so talk to me a little bit about your lifestyle medicine approach, because, I love that it's completely sort of different, but it's tied in with everything that you're doing. So talk to me a little bit about that.
My interest came in from the fact that I needed to upskill myself in understanding what else impacts pain. That was where I came into lifestyle medicine from. But I found that once long COVID happened, it was almost intuitive that we needed to bring that as well into the patient's treatment plan and actually make them aware. And that's what I tell my team. And my team, as such, it's physios, OTs, and psychologists. They probably have been, and GPs, they probably do this much better than I ever did because I came in with a single specialty interest. But they, as physios and psychologists and GPs, would have to already be, you know, intuitively talking about how to do things and adapt to the environment around. I had to train myself, and I did the British Society of Lifestyle Medicine Diplomate, so which was a proper international qualification that I took last year.
You have to
And
be a doctor to do that, don't you?
no, not really. You can be a nutritionist, you can be a
Okay.
healthcare professional, dietitian, any of those, I think, healthcare professional options. Physios have also been able to do it. There is a certain, I think in the US, the physicians have a different kind of exam to give, and the other healthcare professionals give a slightly different exam for their qualification, because in the US, they are given a diplomate by the medical healthcare board. So the physicians have to do a different exam, but the healthcare professionals can do a different one. And then you've got a slightly related but slightly different branch called functional medicine, which is which the proponents of lifestyle and functional medicine slightly view it differently. Lifestyle medicine takes into account that the evidence that they use for practice must be has evidence-based, using mainstream medical models of randomized controlled trials, systematic reviews. And so the advice that lifestyle medicine physicians give is on a bedrock of high quality evidence that is already out there, or work that has already been done to inform how you can talk to patients about lifestyle measures around health, nutrition management, sleep, mood management, relationship, connectedness, and then the use of substances like alcohol, smoking, or medication. So those are the aspects, the 5 or 6 pillars of lifestyle medicine. Functional medicine takes a slightly different track, wherein they come from a systems approach of saying that the gut microbiome and some other aspects of endocrine or hormonal function, if optimized, can improve the whole organism. So they look at all of the same elements of lifestyle medicine and optimize those things, but they are willing to go that 1 or 2 steps further and actually say, can we investigate more for these functional disturbances of hormone or gut or microbiome, and then use various supplements or other stuff to optimize these 3 organ systems. That means that they go into techniques and stuff that is still not yet evidence-based. So hormone testing, gut microbes, that is not mainstream evidence. I think there are case studies that say they work, but it's not the bedrock of evidence that mainstream medicine accepts as yet. So there are elements of functional medicine that I think are still yet to gain popularity, but the principles I think are not far away. It's only a matter of time before what the elements that they do will come into lifestyle and mainstream medicine as we know it. But I think that's about maybe 5 to 10 years in the making. But I find that the lifestyle medicine pillars itself, incorporating that into the care of the long COVID patient, makes it a more complete plan for them. They when they finish their consultation with my team or myself, I'd like to think that they're going away feeling a bit more hopeful that they've received reassurance, they've received validation about their condition, they have got a plan around some medications if appropriate, and they have a plan on what else they can do in order to get themselves back to health. You know, if that means writing to their employer requiring some support around what adaptations they can do to return back to work, to understand and make their employers understand that these ups and downs are part of the COVID recovery and that everybody doesn't recover the same way. Just taking down those stress levels and those threat levels that they otherwise would have been finding it difficult to tell their employer because they don't know themselves. That part itself makes them feel that, okay, you know what, I'm happy that my employer is going to be sorted. I'm happy that I got a bit of drug. Because I've got these 2 arms, I will make an attempt to walk a little further, move a little better, make some adaptations around sleep hygiene, eat a little bit healthier. And I think it's that combination is what we are looking for improvement.
Absolutely. And I know many people have gone on and sought a functional medicine practitioner's advice. And, you know, there's a lot of people sharing their story and their wisdom out there on multiple different groups, because people are absolutely willing, you know, just to help us.
Yeah, exactly.
Where one door closes, you go somewhere else. And there's some very, very, you know, wonderfully sort of dogged, determined people out there who have been out and asking questions and feeding back what they find to the many, many other people who are perhaps unable to or too unwell to be able to go and seek that information. And I think it's essential. It's, you know, like what we're doing here. If we can, you know, change one person's understanding of what that they can do themselves, then, you know, we're already winning. Absolutely. And actually, let me just deep dive then for a moment, because I know, you know, we're beginning to run out of time, but I know that, you know, there will be people watching this who are thinking, I've got pain, real debilitating pain as a result of my COVID response and what's happening in my body. And the only thing that I've got right now in my hand is painkillers. So, you know, let's just have a little, if you can offer any words of wisdom or support for them, that would be amazing, because, you know, I really do know people who are saying, I'm in too much pain to move. I can't do the movement, Susie. I can't come and do that. I'm in too much pain to do breathing exercises. I can't do that. What would be your first port of call?
So I'm going to probably say, first of all, to those listeners, there is pain is going to be, you know, very common in our study data itself. 65 to 70% had pain. And the main thing to think about again is, you know, I again go upstream and actually say, well, what is the cause of pain? And it's easy to just throw a painkiller out there, but I actually say, what would be the cause of pain? And what can be the reasons for someone to have pain coming from various parts of the body? And, you know, if your listeners are anybody like the patients I get in my long COVID clinic, they describe pain that is often intense, severe, numbness, shooting, pins and needles, pain that often travels from one leg to the other or up and down the body, or even in the same day, the low back would be painful in the morning, the neck by the evening. So this is a kind of mobile target that doesn't seem to stay steady or intense in one level. To me and to your listeners, that should automatically convey that this is less likely to be about that particular structure alone. And that I think is quite important, because if you do have an injury, or if you've had a very severe COVID and you've needed to be in ICU or hospital, and you've had some drugs or ventilation or machine or dialysis, that is likely to indicate that there might have been some local muscle damage or changes in there, you know, structural changes.
Yeah.
But for a lot of people who have otherwise not been there, then this is going to be a combination of how the nervous system has got affected by the virus. It may be the autonomic nervous system, or it could be the main sensory nervous system that gets impacted and changed by the virus, which means the virus leaves some of these nerve sheets slightly exposed, so they fire away much quicker, or some of these endpoints where the muscle might have got a bit deconditioned goes into tightness or spasm, and that fires away the nerve even faster. So the nerve firing, which is called peripheral sensitivity, or if that firing occurs within the spinal cord or in the brain, which is central sensitivity, these are the reasons why those signals end up reaching the brain, and the brain actually says, this is where it used to come from, the foot or the ankle or the back or the neck. And it will say, the last time I did this, I made the whole area go into spasm. So this is what I'm going to do this time. So it instructs the muscles in that area to go into spasm, to tighten up and protect that area. So it's all about protection. Pain is about a form of protection. So we've now got the situation wherein somebody's widespread pain after COVID, in the absence of a structural damage, is going to be more likely due to nerve sensitivity, and that nerve sensitivity can be peripherally or in the center, in the central. So managing it, if I have to use the mindset approach, we can start with medication. So it may not be your paracetamol or your codeine that's more effective, because they are much better when there is chemical release after an injury or a fall or a trauma.
Right.
But when you have nerve sensitivity in a periphery, in a knee or an ankle there, then you're looking at possibly a nerve medication. So that would be the more appropriate medication. If there is associated muscle spasm, then a muscle relaxant may be a choice of the a medication to add in. So these may be choices that the patient could consider. There are very few interventions, but I tend to think about, if you want to use an application like a TENS machine,
Right.
or if you wanted to use something like acupressure dots there, then those might be mechanical interventions or heat or cold packs or something
Yeah.
that can just soothe the local area, improve the blood flow, and that can relax some of the muscles there. So that might be the physical interventions to think about. The neuroscience, to a certain extent, we now realize that that pain is going to be partly because of deconditioning and less movement. If there is going to be an added element of stress, because you have to do a job, you got to pick up your child from school, or you got to do some housework, or in the case of you're not able to go back to your work role, or you're having to do a lot of work but not enough rest there, then those are all going to be added sources of stress. Can you mitigate that element of neuroscience and stress? That's the end. Nutrition wise, I tend to talk to my patients about saying, could you consider some form of anti-inflammatory diet? So I talk about the option of looking at your processed foods, looking at microwave foods, because these are all pro-inflammatory in the presence of already existing peripheral sensitivity in the nerves. If you're going to take in processed foods or sugar or Coke or anything else has a quick dietary fix because you just need to get to do something, in the long run, that's going to be counterproductive. So an anti-inflammatory diet is what I push for. And then I give some advice around sleep, maybe just a little bit of wearables or something to start monitoring their sleep to know what gets impacted and to see whether we can use it. I think it's too easy for me to sit down and say, oh, yes, you're in a lot of pain, just go and sleep more. I
It's
think
impossible.
it's not. So I tend to focus on saying, if you are able to move even small, visualize certain movements that you're sitting down and doing, visualization as a technique of movement, combine it with an anti-inflammatory diet and use the timing of the food, then you can actually get to a little bit of sleep related improvement in habit there. Reduction in coffee or reduction in alcohol, that might change the way the sleep cycle starts off. Melatonin is not available in the in the local healthcare landscape, at least not on the NHS.
We
But if
can get it.
exactly, so if you're able to source it, I was about to say
We can
social
get it.
media as an enough source there, then I would say melatonin as an option for there, and then movement, and finally the mind-body therapies. I tend to at least say breathing as an option. I know some patients have said sometimes the chest pain feels so much that they can't take even a deeper breath. That has been a challenge to me. I speak to my respiratory colleagues, and right now that's one of the few things wherein we are saying, okay, can you do a little bit of maybe yoga stretches, maybe some form of distraction style breathing techniques there, because after all, they are breathing, we are breathing, because
Right.
that's,
You're
we are
alive.
doing it. It's the question is, how can we use that to calm the system down? Because if they can do that, then they could engage in other mind body therapies. But that's something I still haven't cracked the nut for pain. How can I introduce, if chest pain is preventing them from doing even simple mind body therapies, then right now I'm sticking with visualization and gentle seated Tai Chi. We got some charity funding. This might be a good time there to actually say, we got some charity funding to actually say, can we provide some gentle mind body therapy? So locally, there are a couple of flotation and deep sea centers out there, some health retreats, and then there's an online Tai Chi for well-being program run by trainers. So we've got a little bit of funding to offer patients access to these courses. We've got a link up with the English National Opera, has a research project to say breathing retraining using singing. So we offer patients these kind of less invasive or less problematic group-based approaches They
Yeah.
say, do you want to do this? Can you do this a little bit? And maybe that kind of movement will encourage sleep, and therefore that will be a mind-body therapy to explore. So that's what I would suggest for your listeners around pain in long COVID.
Oh, good. I'm really glad to hear you talk about that, because I know that, I very much do recommend people to come in, and even if they're just lying in bed, so come into our live group classes. And even if they're just lying in bed and they really, really think, I can't move anything, I'm in a lot of pain, I just say, okay, all you're going to do is move your toes, and then you're going to lift your hand, and then you might turn your head from side to side, and that's you done. But you're here and you're participating and you're with everyone else. And we're not going to let you slip off into the kind of abyss. You're with us, but you're just with us at that really, really basic level. Because a lot of people make the assumption, I need to be well enough to do the class. It's like, no, you don't. You need to just be well enough to log in. And then you can stay in bed and you can have your eyes closed if you need to. And you can just listen to what we're talking about. Because I think people need to feel like they're part of something. They're not just disappearing. Their lives aren't just disappearing off into a nothingness. I think it's
you need to
really
give them
essential.
back that identity and that sense of identity.
Yeah, absolutely. Absolutely. So, I love the idea that you're now getting funding to get people into kind of chair-based Tai Chi. And I know the ENO have been doing their thing for a while, but I also know you need to be well enough to do that project.
Exactly. It is a bit more respiratorily. I think we've had a few patients who've been so fatigued that the ENO has felt not suitable. You're right.
Absolutely. Yeah. So, to have somewhere where people go, oh, I can just log in and that's me done, and I've achieved something. That's great.
Exactly.
So it's lovely to hear that you're getting some funding for those sort of alternatives as well. So really great. So I think we've kind of covered, and I'm aware that we could talk for hours. That's how I feel. Because part of me now, I have a list of questions in front of me, and I'm like, no, I could ask you about, microclots, but I think, that's for another day. Because, as we've said, more and more things keep coming up to the surface as we understand more and more about the different things that are happening for people. And everyone wants to know the answer to this or that or this or that or this or that. But anyway, I think I'm gonna give you your time back now and say a huge thank you, Deepak. That's been really fascinating and hopefully educational for people. I'm definitely going to put your mindset protocol up onto my Facebook group. And we already kind of mostly talk about it a lot anyway, but it's just lovely to have that acronym that we can kind of follow. And I'll definitely do a book review of your book and share that into the group as well. But thank you so much for your time. It's really appreciated.
No worries at all. Thank you so much. I think on the BSLM, the British Society of Lifestyle Medicine thing, I'd done a long COVID and lifestyle medicine webinar, and I think it is
I've already shared that in the group.
You shared that, fine, because that's for public demand there, but that's fine. Good, excellent. That's it.
Brilliant. But Deepak, I'm sure I'll come back to you at some point in the future and we can carry on this conversation. But until then, thank you once again.
Happy to help out your group. Thank you for having me then,
Thank
Susie.
you.
Bye.
Bye-bye.